asked, what would I talk on? It becomes a rather confusing issue. Pushing the boundaries is what I was suggested that I should talk on. Pushing the boundaries of complex high-risk PCI and structural heart interventions. And I guess it's a very good talk because it has a lot of aspects to it, especially for the young gen. And I would therefore start this, it is appropriate to start this, a memorial, USHA Rani Memorial oration, with certainly remembering Dr. Samuel Matthew. And when we talk about pushing boundaries in interventional cardiologists, he was such a highly gifted, iconic interventional cardiologist, a great friend of ours, a teacher, a mentor to many, and of course, he contributed immensely to the growth and development of interventional cardiology. Today, I talk to you also on behalf of my illustrious colleagues and seniors. These are the ones who started angioplasty in this country prior to the days of the stent. They had no footpaths to follow. Dr. M.J. Gandhi, Professor Khalilullah, Dr. Dev Palajani, Dr. Ashwin Mehta, Dr. Upendra Kaul, Dr. Somaraju, Dr. Gambhir, Dr. Sethi, and Dr. Sanjay Tyagi in peripheral vascular interventions led the field and created the footsteps in the stand that we actually see today. So it's on behalf of them that I talk today. Of course, there are many more. There are many more subsequently who followed the path, who've created innovations, who've created many other and have stretched and pushed the boundaries. Of course, some of them have also been trained by us. By the way, pushing the boundaries is not the same as being the first. As you know, there's a lot of race for doing the first case in the country. It is not just a procedure, by the way. Pushing the boundaries is a responsibility. It's the start of the journey. It also starts off with creating science, research, evidence for whatever we do. We need to continue to upgrade our skills when we push the boundaries, and we then share knowledge with each other so that we upgrade others and ourselves each time. We also talk about teaching and training our juniors and creating courses, and we develop therapy for the patients and the nation. So when we push boundaries, it takes into account all that. It doesn't take into account the first procedure performed in the country. When we push boundaries, it also means coming out of our comfort zone. It's a difficult task. Sometimes it's like mission impossible. It helps us to learn and grow, to innovate, and of course, look at new opportunities which inspire everyone. This is what the greats on those photographs I showed you, the greats did. The race to be the first continues. Obviously, it's the natural spirit of professional competitiveness. It's nice to see yourself on a WhatsApp being complimented innumerable times. It's an obsession. Some of it is cowboyship. The WhatsApp hero always remains with us. But we must ensure patient safety. Do not pretend to be demigods and lost and mesmerized in the present advancements of science and technology. And we must remember that there are others who actually sit in this audience who can do anything better than I can do. With these words, today we will talk about what did we really do. And I say it for my colleagues who really are pushing the boundaries, why and how we did it, and what can we educate and transfer to the young gen early career interventional cardiologists. What are the learnings they can take from us as we push these boundaries and broke barriers? What did we really do? Goes back to October '88. After 10 years abroad, I came back to the country and started the first angiogram and the first angioplasty of the Fortis Escorts Heart Institute as a young 35-year-old and head of the interventional cardiology program. That was the balloon angioplasty era, pre-stent. We had 9 French guides, we had no antiplatelet agents, we had Kroon balloon catheters which could not cross the lesions, we had cut films to look at and guide angioplasties, we had no fancy roadmaps, and yet we had huge amount of complications, 10% vessel closure, 5% MIs, 3% deaths, and always requesting the cardiac surgeon to have an OT standing by and giving us the permission to go ahead with a balloon angioplasty when actually all the time he felt that we were competing against him and perhaps he had to bury angioplasty much before it even surfaced. And restenosis, even if patient lived, would come back in 6 months with a restenosis 50% of the times. I want to really acknowledge the greats who then took me also as a partner. Dr. Ashwin Mehta, who sits here, Dr. Dev Palajani, Dr. M.J. Gandhi, Matthew Upendra Kaul Gambhir, K.K. Sethi, Somaraju, Ashok Seth. We were the only few who were doing angioplasties in that area. And we therefore decided to create a club in 1989. The 10 of us met together. Like I said, they were already the greats of the country. That's why I say I'm privileged that I was accepted by them in my early days here. So at Hinduja Hospital, we met, we discussed cases, we shared with each other. We actually learned from each other as to the more and more complexities that evolved in front of our eyes. We broke boundaries, yes. This would make many shudder even in the present era of stents. This is a time when I actually took up this case in '92, balloon angioplasty, no stents, no good antiplatelet therapy, no bailout. Right coronary artery, which you can see, is long and diffusely diseased. We have a left main arising from the right coronary sinus. I think I'll just take a pointer here. Yeah, we have a left main arising from the right coronary sinus, and we have an ostial LAD right there, and then there's circumflex, multiple lesions on the circumflex. This case represents the only such report in the literature even at that time, and the technical details were discussed, but I'll tell you that when I completed this case with balloon angioplasty all in a single sitting, because I thought I was Jeffrey Hartzler, the patient survived. And when I then sent this for publication, the journals refused, saying that we do not want to use balloon angioplasty or your case as an example because that's cowboyish. We don't want to have this. And anyway, the patient lived. He, 2 years later, had chest pain. He underwent an angiogram, and he had a new lesion in the distal right coronary artery, and all the lesions which had been treated by balloon angioplasty were fine without restenosis. When I now sent this was 92, I sent this in 95. It got published saying, wow, balloon angioplasty works. Thank you for demonstrating that. Those were the days we were pushing the boundaries. Directional atherectomy came in, of course. We're talking about devices to cut inside the coronary arteries. In 92, and this is the sort of stuff which we could do. High-grade ostial stenosis, cutter, cutting out plaques from within the coronary arteries, 10 French guiding catheters, 8 French cutter, and we could cut the plaque from within the coronary arteries and leave behind a pristine artery and take out strips of atherosclerotic plaques from within coronary arteries. And perhaps in the absence, because we didn't have stents, we could actually advance the technology to deal with every type of blockages, including bifurcation lesions, long lesions, and dissections even. Rotational atherectomy, we introduced rotational atherectomy into the country. It was Matthew, it was Upendra Kaul, it was Dr. Mehta, and myself who pushed this technology, not just for India, but perhaps for the Asia Pacific, and taught Indonesia, Philippines, Malaysia, Thailand, Singapore, and went to China also to train people, because we were doing extensive rotational atherectomy, and we were the first center outside United States to start teaching rotational atherectomy through program courses. Well, there were numerous firsts which happened subsequently, but in my own life, it was a live transmission to the TCT USA, to the main arena in 2003, which was important. Let me just say that the present era of mechanical circulatory support and cardiogenic shock started off with us in India. When we used Impella 17 years ago, 17 years ago, many of your young gen interventional cardiologists perhaps would have been in school, not even in the medical colleges. And we actually did it in cardiogenic shock when we airlifted this patient who was in cardiogenic shock and had an NMI. He had diffuse triple vessel disease. He was 83 years old. He was on a ventilator. He was on a balloon pump. And that was the first time in Asia. We implanted an Impella in April of 2007, revascularized his triple vessel disease, including left main. The guy survived. And that was absolutely the start of a new era of mechanical circulatory support, not just for India, it was for Asia. It was the United States at that time didn't have Impella. It was into its first study, which was PROTECT. For the first time ever, I was invited to demonstrate Impella to the main arena of the TCT for the first ever Impella cases that had ever been done at the TCT. It was a privilege of India. It was a privilege of ours. It was a privilege of all my colleagues, many of who sit on the podium and in the hall, that we together did it. We were demonstrating at 12 o'clock at night. It was 9 o'clock Washington time. And this was a beautiful demonstration of most treacherous cases because these were patients with ejection fraction of 20% and recent heart failure. But actually, like I said, you need to develop therapy, and that's what we did. We therefore transformed this mechanical circulatory support to a master's conclave in 2020 at the CHIP CTO meeting. Together, the thought leaders of India got together to say which patient needs mechanical circulatory support, the transcatheter percutaneous microcirculatory support with Impella. And we created this consensus document, which we published, creating a new scoring system for India to decide which patients should, high-risk PCI patients, should have PCI on intra-aortic balloon pump and which patients should go onto Impella microcirculatory support pump. Well, this is another chapter in our own history, the absorbed biovascular scaffolds. I was the first one to implant it in 2010 in the whole of Asia, but it was also part of an absorb extend seminal study, a 1,000-patient study, of which the Indian arm of 100 patients I was a principal investigator of. But it's not just that which happened. The journey with absorb was phenomenal. I contributed, or we, I would say, as nation, contributed immensely to the science and to the knowledge of optimization of how to use BVS to the best safety and best outcomes of the patient. And our literature transformed some of the ways this technique had been performed across the world. Not just that, we were partner to numerous international bodies in creating numerous aspects of developing science and technology with absorbed BVS across the world. But the seminal part of it was that we also created the technique of doing bifurcation lesions using two absorb strategies, what we call the TAP technique, where we described it as the first ever case reports and technical considerations, and then were asked to demonstrate this bifurcation absorb to the main arena of the TCT. Clearly, a great tribute to the leadership of India and the leadership of the Indian key opinion leaders as we push the boundaries of this technology. Yes, it was a privilege to be invited to the FDA to present one of the largest experiences of the world, which was ours, to the US FDA panel in 2016 at the time when their trial was presented. That day, after all this, at the end of the day, the absorb got approved in the United States. And then we moved to our own indigenous technologies, the MIRIS 100, the 100-micron scaffold, which we therefore put into the first in-human study, presented it as a late-breaking trial to the TCT main arena. The 3-year data got presented to the PCR main arena, and that was published simultaneously in Eurointervention. Going on to structural, the first in-human study ever, the first case ever in the world in 2004 of the self-expandable valve happened in India with us as a part of the first in-human study. And then, of course, we moved on to the commercial use of this device into India in 2012, and therefore were privileged, to not just introduce it, but to develop more conscious sedation in this country and contribute to the international literature on bicuspid aortic valves, which even got published in Nature Review Cardiology for creating a roadmap for bicuspid aortic valve. Nothing is complete till you actually have research and science. Pushing boundaries does not mean the first case. And we were therefore privileged to have the Indian valve, the MyValve, and I was privileged to be the principal investigator of MyValve to the first in-human study, presented at a late-breaking trial in the PCR with a publication in Eurointervention. MitraClip 2018, but the fundamentals, let me just say, in the last few moments that I have. What are the messages? The fundamentals of pushing the boundary. The fundamentals for our new generation of interventional cardiologists is not to be mesmerized. It's to learn the techniques, learn the technologies, which all greats of interventional cardiology understand and realize. Even at this time as I talk, all that I've shown you, and many of whom sit in the audience, know this fact and teach every day that we need to be masters at numerous techniques and technologies, but we also need to understand hemodynamic support. I had written this up much earlier, perhaps 5 years ago, in this editorial in CCI, that a dedicated, defined, all-round training program with proficiency towards complex PCI in high-risk patients is utmost important for every country across the world as we push the boundaries and as we see more and more complex PCI patients. We need to give them our best, and that is why education becomes an integral part of what we do for our early career interventional cardiologists. With my colleagues who are on the dais and with others who are sitting in the audience and perhaps not here, we've created educational programs which have transformed the nation into really pushing boundaries. The India Live you well recognize with Dr. Mehta as one of the chief coordinators of the program. The CHIP CTO India, again, which I partner with some of the greats here, including Dr. Mehta himself, to create complex angioplasty, to teach and create a platform for teaching and training complex angioplasties. The India Valves, a seminal program for learning valve therapies and structural heart therapies. The Imaging and Physiology Council of India, which we created for really optimization and precision-based PCI, which is the need for complex PCI, and of course the AICT Asia PCR, which has transformed the whole of Asia. Let me just give me a couple of minutes because the messaging will be very clear. This is the sort of case where we dread, but this is the sort of case which also teaches how we push the boundaries. This is case being done live. Anterior MI, heart failure, low ejection fraction, bad angina, surgical turndown, you name it, he's a high-risk case. He's got raised PSATs, he's got low PSATs, he's got raised PA pressures, he's got the most diffuse coronary artery disease that you can ever see. There's nothing there for the surgeon, there's nothing there for an interventional cardiologist. And in a live case, then we decide how to do it. And if we decide how to do it, it requires judgment, it requires skills, it requires multiple devices, be able to use multiple devices. It requires understanding of hemodynamics and and mechanical circuitry support. It requires intravascular imaging and interpretation, optimal results, shared decision making, but the patient has to survive, is my final answer. And he has to do well. Because you're not there to be a cowboy. You're there to actually make him live. So what do? With CTO skills, we open up, we put an impeller in. We put a CT, with CTO skills, we open up the circumflex. We then think of that intermedius, which is diffusely disease, and with rotational atherectomy skills, we actually rotablate the whole of the intermedius. And then with drug-coated balloons as a technology, we actually deliver drug to that intermedius. And then with the intravascular lithotripsy, we do the LAD ostium, we do the circ ostium, we then do ultra-high pressure balloons to 30 atmospheres, and then we put up bifurcation stent and give the patient a remarkable result after 3 hours on a supported PCI. Many of you would remember this case. At 6 months, he was asymptomatic, walking 3 to 4 kilometers. Ejection fraction improved to 45%. At 2 years, exactly 3 months ago, I saw him asymptomatic, walk 5 kilometers, enjoying life, business flourishing, doing great. The West considered us. Why did we do all this? Dr. Mehta, Sanjay Tyagi, and others would remember why we did this. I say it for you. The West considered us a third world, didn't they? With inadequate skills and the treatment options. We believe we had the skills and the region needed advanced techniques to be available in India for a fraction of the cost. And we wanted it to do it for the region and the nation. We wanted to create a new respect for India in the international interventional community. We had a dream, we had a vision, we had a mission. If anyone could do it in the world, we could do it better, we felt. But you can't cross the sea merely by standing and staring at the water. You need conviction. We need to benefit our patients. They are not there for testing. We need to meet an unmet need. They need to benefit from it. We need to have competence, expertise, skills, and knowledge. We need confidence. We need to be the best. We need to know that we can do it on our parents even. And the biggest is that we need to have conscience. We need to have ethics when we do this. Professionally, we need to continue to train well and be students forever. That's what even Dr. Mehta, who I consider as the most senior, practicing, competent, interventional cardiologist with great skill and expertise, continues to evolve and learn every month and every year. Aim for perfection, there are no shortcuts. I say to my junior colleagues, be aggressive, but know your limitations. They have 3 eyes, one which looks at the guiding catheter, the ostium, one which looks at the lesion, and one which looks at the distal tip of the wire. Because that's the way you avoid complications and have 5 brains, because you need to think 5 steps ahead. Have a team, be a team player. You're not alone in this game, and debrief and learn from each case. But things can go wrong. Guilt, patients can die on the table when pushing the boundaries. Guilt, remorse, sadness, and introspection. Why? How? Why should I have really done it? Can happen to all of us. But what saves us is ethics, the conscience, the integrity. That's our destiny. It is our light which guides us. And therefore, when we push boundaries, I have to say this in my last 2 slides, and thank you for the fact that I've been over time, but you've all accepted it. We owe it to our patients because we are doing it for them. They come first. They are our relatives. We owe it to our colleagues when we push the boundaries on our juniors. They've got to see inspiration and aspiration amongst us. They need to trust us. They need to model themselves on us. They need to be in the cath lab and be able to do it appropriately and with safety. We owe it to our families because it's their sacrifices which make us do all this. And we need to give them time. And we also have to trust our God, whichever God you trust. Our glory and success is a perception. But the patient's lives is not in our hands, it is in his hands. And he creates the success for ourselves and the patients. So remember, when we push boundaries, we always say, thank God, you did it for us. Thank you.
Ashok, I think it was a combination of philosophy, inspiration, guidelines, and this was not a talk, it was a music. Congratulations, Ashok. Very well done.
I think for this wonderful talk and his work in the field of cardiovascular intervention in India, he deserves a standing ovation. May I request all of you to please give a standing ovation to Dr. Ashok Seth.